All right. Okay. Well, welcome. My name is Kimberly Quinlan, and this is your Anxiety Toolkit podcast. Today, I have a guest speaker, Sara Vicendese, who's going to speak with me about the topic of today's podcast, which is finding your village. The reason I wanted to really work in this topic as a part of the Mindfulness and Anxiety Toolkit podcast is when we're raising a child, we talk about this idea of, or it's actually a phrase called "it takes a village." And the idea of this phrase is it comes from African culture, as far as we know, in terms of research. But it's basically talking about an idea that it takes a large community to raise one child into a thriving adult who can succeed and is healthy. And I believe that to be very true of anyone who's suffering from mental illness as well, or even any type of mental health issue. So I have today Sara to speak with us about how we can create or find our own village to help with whatever they're struggling with. But before we start, I want to make sure before we move in that everyone understands that this is not us saying in any way that you need to have an entire community for you to recover. What we're talking about specifically is creating possibly a micro village, including therapists and getting the right resources and finding the right organizations and including the support group that you have. That we're not speaking in terms of you having to have a large population. So welcome, Sara. I'm so pleased to have you. I'm going to ask Sara some questions. I'm going to let her be the professional person here. Okay, so welcome. And Sara, do you want to tell us a little bit about your practice?
Yeah, I am. Thanks for having me, first of all. I'm located in Westwood, California, and I have kind of an interesting background. I was trained in both psychodynamic therapy, which is commonly referred to, I think, as talk therapy, and CBT, and within cognitive behavioral therapy, which we call CBT, different elements of that, ERP being one of them, and I'll explain a little bit about what that is.
Great. Okay. So I'm going to ask some questions here. So what is the most effective form of treatment for OCD, and how do I find a therapist that provides it?
Well, I think before I get into that, one of the things that I think is the most important for people to know, and I talk a lot about this, is that there are a lot of different types of therapy. You and I know, because we were trained in this, that there's psychodynamic, psychoanalytic, EMDR, brain spotting, ERP. I mean, there's so many, right? But I think for most people, they don't really know that, and so they have this idea in their mind of what therapy should look like. And I think for a lot of people, that's two people in a room having a conversation, sharing their feelings and thoughts. And for a lot of conditions and life situations, that's really effective. And then other times that might not be enough or be the appropriate kind of treatment. And so within that, there's also this assumption that every therapist is the same, right? That it doesn't matter, you can look in a directory, you can find someone, and not everyone with a degree is going to be able to help you in the same way. They might not all be the same fit, and most importantly, they might not all have the same training that you need to recover from what it is you're suffering with. So it's really important for us as clients to be able to know, to be smart consumers, right? To be able to know that you can ask questions, you should ask questions, you should know what you're looking for. So I hope I'm able to help in that way a little bit today. So to your original question, research strongly suggests that the most effective form of treatment for obsessive compulsive disorder, which is the disorder I most commonly treat with ERP, but other severe anxiety disorders as well. It's a therapy called exposure with response prevention, and that's what I'm talking about when I say ERP. And for many people, successful treatment also includes medication. So a psychiatrist is often a part of the team as well. So quickly, what's that going to look like in the room? Because I can say that, and then you kind of might wonder, okay, it's not two people just talking. What does that actually look like? And I think it can feel very different. It will feel very different from that in the sense that if you have a fear, if you have an anxiety about something, it's pretty common that you want to avoid that. And our job as ERP therapists is to look that fear in the face.
Right.
Not just talk about it, right? But actually it's chasing you, right? Like turn around, look it in the face, do that in session with the therapist, have homework, do it again and again and again until it's just not as scary anymore. And that requires real active participation on the part of the client and the therapist. And that, if you're not willing to do that work, it tends to be much less effective. But it'll be more active.
Yeah, very cool. Very cool. So, next question. How do you know your current therapy isn't working?
That's a really good question. So a lot of therapists will say, I think most will say, things can get worse before they get better. And that is not necessarily wrong. I think that is often the case in the sense of you think about what we do, right? No matter what we're trained in, therapists help people feel. And if you're, neither one of us at this moment would choose to feel extremely anxious or extremely angry or sad or grieving or loss. But it's not our job to take that away, nor could we. Right. I mean, really, if we're being honest. So our job is to help you feel. So if you've been doing compulsions or doing a series of things to avoid feeling anxious, and my job is to help you feel that anxiety, what I often tell people is, and I always kind of try to make it light and say, I don't know how this is going to sound for you. My job is not to help you feel better necessarily at first. My job is to help you get better at feeling bad. And then they look at me like, why am I here? Like, this isn't what I signed up for. And I usually wait till we have a good enough rapport before I say
right.
that. But so that's true. But on the flip side of that, it's okay to expect results, right? You're coming in, you're paying a lot of money usually, you're working really hard. So you should have goals. You should talk to your therapist about what your goals are. You should have a sense that you're working towards them. You should be able to have that conversation with your therapist. Hey, I came in here because these symptoms are getting in the way of my life. And I can't function anymore in extreme cases, right? And I don't want to live like this anymore. And I want to reduce my symptoms, and I want to move on in my life in these ways. And that's why you're there.
Right.
So if you've been in therapy for, months or even longer than that, and you're not seeing a movement towards those goals, or worse, if you're starting to feel worse or decline, you don't need to take care of that therapist's feelings. You don't need to continue to support their practice. You can have that conversation with them. You can say, hey, look, I came in for this, and I'm frustrated. And they may say, you know what, I get that. Here's the way I view things. I think you're working towards this goal, and it's realistic. You stick with it. They may be right, or they may present that in a very convincing way because they truly believe it. And you can look at them and say, you know what, I'm going to try something different. I can come back to you, but I'm going to go try this other form of treatment because I'm not feeling better. Life's too short, right? To not feel like you've tried everything.
Right, absolutely, absolutely. Which is a great sort of segue into the next question. What advice do you have for those who cannot find an ERP therapist in their area, or for those who can only afford in-network therapy, where the therapist doesn't know about ERP?
Yeah, so that can be difficult. I mean, the truth is, even in Los Angeles, I feel like there aren't a ton of trained ERP therapists when you compare it to the number of talk therapists or other kinds of therapists out there. And so, especially on insurance panels.
Right.
it's really hard for me to find an ERP therapist that takes insurance. And we could talk about, that whole situation another time and why that is. But I think it takes some proactivity. I know it does. And so what I always tell people is to OCD Center of Los Angeles, I think, is a great place to start. I know you train there. And the International OCD Foundation, go to that website. You can find a directory of people. UCLA has a great program. They have a few. They have a really, and they do take insurance. They take a lot of different types of insurance. So an intensive pediatric program that is 4 days a week, 2 hours a day. Once a week adult exposure therapy, outpatient, you show up once a week, and a more intensive program for adults. So that's where you can start. But if you cannot find that, right, then you can go and you can educate yourself in a couple of different main ways. I think going online can be a blessing, it can be a curse. You can go down a rabbit hole, go in and put some symptoms in and look at WebMD and then spend the rest of the day feeling horrified, right?
Right.
Things you can have. Yeah. But again, those places that I just mentioned, the OCD Center, IOCDF, they're great places to go. Your website is a great place to go.
Thank you.
The OCD Workbook by Dr. Bruce Hyman, Hyman, and Sherry Pedrick. I recommend that book for everyone I'm treating, but I also recently recommended that book as a good example of what we're talking about. You can only afford a therapist in network. You show up, and they aren't trained in ERP. Happened to me the other day. Someone called and said, I'm in this situation, what do I do? And I said, okay, here's what you can do. You can get this book. You can get the book, you can have the conversation with the therapist. And actually, they signed a waiver so this therapist could call me, and it was really cool because it really means a lot to me when a therapist understands something is outside their scope. And they're confident enough to admit that. Why do you know how to do this if you haven't been trained, right? Right. So I told her and the client, I said, get this book, read it. The therapist should read it ahead of time and work through it together. It lays it out pretty well. And educate yourselves at the same time. That might not be ideal. And I said, look, you can call me and you can, to the therapist, you can ask me questions when you need to, but I think that's a really good thing to do when your therapist is open to it. If they're not open to it, that brings up another kind of list of questions I have as to why they're not. But I think that's something you can try. You can also look into Skype therapy. I know there are people, if they're licensed in your state, like John Hirschfield, he may be completely full. He probably is because he's so fantastic. But there are people, it's rare, that are licensed in California but maybe live in other places and provide Skype therapy. And it's rare, but it's wonderful that you can do great work on Skype, and you don't necessarily anymore with technology have to be in the room with someone. Right. For some treatments you really do, but a lot of times you don't, so that's another thing you can always look into. Great.
And for those who are struggling with BFRBs, I would recommend the same thing, is go to bfrb.org and look to see if there are therapists, or on their website they also have workbooks that you can give to your therapist who isn't trained in CBT. So great. That's exactly, I agree on all of those suggestions. In addition, there are some really great podcasts out there specific to some disorders. I know there is OCD Stories, which is really great at just giving advice on different OCD symptoms and ways to work around it. So very cool. All right. All right, Sarah. Just also for the listeners, the first part of the podcast, I'm talking specifically about treatment planning and treatment tools in terms of building your village, and then we're going to go more into building a support system around you and how to effectively communicate your needs. Okay, so what advice do you have for those who want to start? Oh, forgive me, I just asked you that question. No, what advice do you have for those who want to start ERP but have a non-ERP therapist? What advice do you... Did I just ask you that?
Well, you know what? No, I bled over into
Yeah, we are so onto it today. Okay, let's move along. Yeah.
Well, no, actually, there's something about that I would want to add, because there's really, and I kind of went over it, but there's really two choices, right? There's you can leave your therapist. This is assuming, and I think this is where the two questions kind of veer off, is that assuming you can find an ERP therapist, and they're across town from your current therapist, within, they're around the same area, and you want to start that. And there are really two options. You can leave your current therapist to start with an ERP therapist, or you can explore the potential of seeing both at the same time. And that's something that I really wanted to talk about too, because I was trained kind of initially in this very pure form of you don't ever have two therapists at the same time. That's unethical, and it can be tricky, and it can be unethical if the therapists don't know about each other. That's really not a good situation to be in. But also if you're trying to do the same thing, or if you're working against each other. So, as a dynamic therapist that does a lot of more supportive talk therapy work, recently I was working with someone on the grieving process, not to go into too much detail, and they had something crop up that I felt like really needed ERP. And I don't try to do both at the same time, because the truth is you really can't. You need to focus your attention. And so I said, yes, I can do that, but the client was pretty clear, I need you for this other thing too. I need. At the same, did I lose you for a second?
I lost you just for a second.
But, well, you were very still, so I thought you were either very interested in what I had to say, or...
Both. I was both. I was interested and stuck.
Yes, but no, I'm not that interesting. So I'm glad I have you back. It's basically the point that I'm making is that I stayed with the client that needed more supportive work and referred out. And I have also been the person who has been called by one of my psychodynamic colleagues more than a few times. And they said, I'm out of my depth on this, but my client doesn't want to leave me, and we work together.
Right.
To do that effectively, you need to collaborate. It has to be a constant conversation, and you have to be willing to be educated by the ERP therapist about what it is you're doing. And one of the most common things I think can happen, just as an example of when it doesn't work as well, is compulsive reassurance seeking is a big part of OCD for a lot of people. And I found that they're getting that from their therapist.
Right.
I'm a bad person. No, you're not. I'm a bad person. Why would you think that? Even CBT, right? Let's challenge that thought.
Right.
There's no evidence that you're a bad person. And when they get in to see me, it's oftentimes like, let's talk about that. Let's write stories about how bad you really are, right? And so there needs to be an understanding of what's happening there, and how maybe I can take away some of that reassurance seeking to better do that work.
Right.
Yeah, and then the other way that can, I think, be difficult too is when there's an over-analyzing of what's happening. So I have an intrusive thought that I want to hurt someone. If you go too far down the road of when did you start first wanting to hurt someone, and why do you want to hurt someone, and how difficult that is, because as you know, not all thoughts have meaning.
Right.
And not all thoughts, are thoughts that we want to have, and typically they never are if they're causing us that much distress. We're not obsessing because it fits, right?
Right.
It doesn't fit. So anyway, there has to be a lot of collaboration between the two. And everyone has to stay in their lane, because if they don't, then it can kind of get tricky.
Right, right. And just to add to that, I agree with everything with you're saying, is often I'll get referrals and they've said on the message, my doctor told me I need a CBT therapist, which is correct, right? But CBT it looks different in many cases. A CBT therapist who works with depression will spend a lot of time restructuring thinking. They're not going to be the CBT therapist we need if you have OCD or hair pulling or a phobia, because spending too much time on the cognitive component can also be dangerous too. So I think you're absolutely right in terms of the question being specific to ERP, not just CBT.
Mm-hmm.
Right,
Yeah.
right. Okay, let's cross over to now talking about building a support team within the family or friends or partners. Sara, what advice do you give the family members of those who are struggling with mental health issues such as OCD and BFRBs or even eating disorders? What would you say to the family members?
Well, a couple of things. I think initially I always have them get the book, or they can borrow mine. I have a few copies if they can't get the book, of When a Family Member Has OCD by our colleague John Hirschfield, Hershfield. I better have gotten that right. It's fantastic, and it's written in such a conversational way, in such an empathetic way, and it's really been helpful to every single person that I've given it to. And so psychoeducation is really, really important. And I'll be curious if you have thoughts on other things, because there's a lot out there. But I'm just comfortable with that one because I know what it says and I'm comfortable with it. But involving a family member in treatment is really important too. If they're willing to be in treatment and they're helpful and supportive. I know you're going to ask me a question about that, I think, a little bit later as well. But assuming that everyone's supportive and wants to help, it's not detrimental to treatment, I will bring the family member, the parent, the spouse in, assuming it's okay with the client. But I really stress that it's a team effort, right? You go home from my office and you're in this world, and if the world isn't working with you, that's tough. So I'll offer educational sessions and I'll say, this is what your loved one is going through. This is what treatment's going to look like. And this is how you can best support them and build empathy and understanding from their side of things. Living with and loving someone with any severe or moderate mental health issue is very difficult on everyone, and it's critical that the family and the support system is healthy as possible to thrive too. For the support system and the people in it to seek out their own support, and I'll talk a little bit about that in a minute, is really important as well.
Right, absolutely. Is there any kind of therapy that can benefit the spouse, this is what you were just speaking about, or parent or family member of someone with OCD or another anxiety disorder or BFRB?
Well, thank you for asking. That did lead into that quite well. So, it's always a great sign when people want to help, right? And that's a great place to start with. So I think you can probably hear my garbage truck outside because I'm in my home office.
It's so right on time. Right on time.
I know, right on time. So one option that's available is a group support setting. They offer that to people up at the UCLA program in the pediatric intensive program. I only know that because I worked there for a few years. It might be a part of other treatment that they provide. But once a week, if not more, the families get together and the siblings get together and they talk about what it's like to live in that world and to be able to support their loved one. There's also a lot of information online, like I talked about. Super important to consider the source and go to those websites that you and I talked about. And I think individual therapy is a really good idea if it's accessible for you or for the person. preferably they would have some understanding or knowledge of OCD and ERP, but I don't necessarily think that that's the only way to do it. If you're struggling with depression and feelings of being overwhelmed and, all the stuff that can come up around that, I think a good supportive talk therapist, they would call themselves psychodynamic probably, can be extremely effective,
Right.
in helping people process all of that, all the difficult family dynamics that can come along with that. I personally offer sessions to the family members, like I said, but I'm pretty careful, to get consent, right? But I'm also careful I don't then go into, I am here to support you. I make it very clear, and say something to the effect of, I'm not enough for you.
Right.
But I'm here to help you in the context of them. But I'm going to be pretty disappointing as a therapist for you because I'm not giving you that. I'm not your therapist. And I'll make referrals to somebody else.
Right. Absolutely. Okay, what can a sufferer do when their family member or friend is not supportive of their recovery?
That's a tough situation to be in. And I think being unsupportive can take many different forms. It can go from simply not understanding the treatment or participating in it to the other kind of extreme end of working against the treatment, purposely interfering with it. Someone who's not supportive is in some way, we call it colluding with the illness, in some way supporting it. For some reason, they don't really want you to get better. This is the extreme end. And in kind of an example of that is I've seen this situation where a family is, a partner is going through ERP, and that can stress the relationship in the sense of, let's say, and this is, an example that I've experienced where one partner is going through kind of a lesser form of the same thing. So one partner is really debilitated by contamination OCD, for example, and really can't function anymore. And the person they're living with can kind of get through their day, but is using a ton of Purell and is still wiping down surfaces and is still somehow communicating dirt is dangerous.
Right.
So all of a sudden, their partner starts to do all this work, and the family member, is struggling with that and communicating something very different than what we're trying to, which of course is, maybe dirt's dangerous, I don't know, but you're just going to have to live with it and not use Purell anymore. So in that case, and when it's genetic, when it's a parent or, then oftentimes, we know it's highly genetic. And so are highly common to pass down to children, for example. I always say, I bring them in and I explain how they may be interfering with treatment in a very compassionate way and make a referral for their own.
Right.
And if they won't do it, try to help the client understand that this is about them. And while it's hard, you have to do you. I'm not young enough to say that, but you do you, right? Like, you have to take care of yourself. But that's tough. And also, I think, and this I've seen quite a bit too. I think this is the more common one that I've seen, where I'll see adolescents or children or an adult, and the person in their life doesn't want to see them in pain.
Right.
They've been seeing them in this immense amount of pain for quite some time, and so they come in and they expect to see these results when my loved one isn't going to be in pain anymore. And all of a sudden, they're doing these exposures at home that are highly anxiety provoking. So, in an example of one that I can think of, they're doing the exposure at home and trying really hard to tolerate it, and in flies the well-intentioned loved one and tries to save them. Don't worry, if this isn't real, you're okay, and just interferes with that. And I get it. It's really hard. It's hard for me as a therapist to sometimes do this stuff. I have to remind myself of how it works. Otherwise, it feels like I'm just making people suffer.
Right. And I think too, what could be helpful is, and I can actually post this in the show notes, is there is an assessment called the Family Accommodation Scale. And so for those who are wondering whether or not they are doing that rescuing behavior, I'm sure there's lots of like free PDFs online that you can download you can go through and see whether you're doing any of those rescuing behaviors. Because sometimes people don't even know. They think, of course, as a parent, I'm going to tell my son that no one's going to harm him, right? That's my job as a parent. But if that child has OCD, you're actually working against the therapist. So I will post information about the family accommodation scale in the notes as well.
Great.
Yeah.
Yeah, in my experience, most people get on board given enough time and education. It's not always the case, and there is the tough decision that needs to be made if, like, say it's a friend or someone. It's hard. You can't cut out a family member really easy, and I don't really believe in cutting people out anyway. But if there's a friend or someone in your life that, for whatever reason, is helping keep you stuck and is really consistently working against you, for a variety of their own issues, then you might want to second guess that relationship. It's not unlike, when I'm helping someone with substance abuse.
Oh, I lost you again.
And their friend not with.
You're back.
Did I lose you?
I got you.
Hi, I'm back. Yeah, I was saying that it's not unlike when I'm treating substance abuse and their friend keeps calling them up and saying, come out to the bar. You didn't have a problem. Come on, you're so fun. Come by around. And, you can try really hard to resist that. But that person, at the end of the day, if they keep doing it, they're not supportive of your recovery, and they're going to lead to relapse. And I think it's totally okay, as painful as it is, to clean house and get rid of the people in your life that are helping keep you sick. It's tough, but sometimes necessary.
Right. And I think too, I think sometimes it might be just a little bit of communication education is if you're struggling, let's say you have OCD or BFRB or even any eating disorder, depression, whatever it might be, it's also up to us as the sufferer to communicate what does work for us by saying it's really not helpful when you come and clean the counters for me, or it's not helpful for you to come and soothe me. What I really need is I need you to look me in the eyes and tell me, I'm here for you whenever you need me, and to give you space. So I think it's also on the sufferers and that communication of like that. This is where what I do need.
Mm-hmm. Yeah, absolutely. And then the therapist can help with that too. Help people script what they need to say and educate people.
Right. And do you have any other thoughts in terms of what you could do, let's say if there's a partner or a family member who isn't supportive?
That I haven't already said. I mean, I think besides bringing them in, you could limit time. You could limit time with them. It's, if you're a kid, you can't limit time with your parents. But if you are working on something and they just can't get on board, you can do your exposures and your work out, without them nearby. That's okay too. If it's just too hard for them to see you without rescuing you, you can do it in your own time, because that might just be too hard for them to see.
Right. Absolutely. Yeah. I always think I've had several clients who've gone through an entire treatment plan and of exposure therapy without telling one soul that they were going through what they were going through and that they were getting treatment for what they were going through. And I thought, and the reason I bring that up as we sort of get ready to conclude is that didn't mean she didn't have a village, because she didn't have the people on board. She knew the books that she had to read. She got the resource she needed to get. And for anyone who's listening here, you're already obviously clued into resources. You know where you should be listening and where you should be reading. But her village was just knowing there are other people out there. You know, she knew that every day of the week there were 5 to 8 people coming into my office doing exactly what she was doing, and that was the support she needed, just to know others were doing it. She didn't need anybody. I mean, she would have liked someone, I'm sure, but she chose not to. So I think that is really powerful, in knowing that you can do it on your own if necessary.
Yeah, and as I'm hearing you talk, I'm thinking about individuals who confess a lot. That, what that looks like is, right, you have a thought and you feel like you have to tell someone. And in that case, yeah, I have, it's been less of a joint process because in, relationship OCD, ROCD, I'm constantly saying, we're working on not telling people things.
Right.
And so in that case, I don't really want that person to be part of treatment if it means that they're constantly hearing about all the questions you have about the relationship and all the things that are wrong with them and you. So keeping it internal can be a key part of that process too. And again, it doesn't mean they don't love you or that you don't love them or, or maybe it does if you're doing an exposure.
Very good point.
Yeah. Maybe it does mean you don't love them. But yeah, that's we're talking.
Right, absolutely. Very cool. Okay. Well, this is sort of off the cuff, but is there any advice you would give for someone who needed to build a village or wanted to build a village in whatever way that was, in whatever shape or form that looks like?
I think I'm hoping that if by the time they're listening to this, if it's the client that is the one listening or someone that's suffering, you already have a village. You just might not know it. You are not the only person that's going through this. There are so many people that empathize with you and have been through it, and that would get their arms around you if they could, all around the country and world. And so, you can go to message boards and hopefully ones that where people are being helpful. But you can go online, you can create a community, but just know internally that, because I think there's so much shame and so much of this, and so much thinking that you're wrong or bad or not good enough. And that's heartbreaking, because once you know what's going on, a diagnosis is the best thing that can happen to someone. There is nothing wrong with labeling a person, right? If it means that you know what's wrong, you know how to treat it, and you're not alone, that's huge.
Right.
So I just want people to keep that in mind too. You're not alone.
Right. Absolutely. Yeah. Okay. That's wonderful. So thank you so much for your time, Sara. It's been a pleasure speaking with you. And I'm hoping that, you really give a really great insight, given that you are trained in both the, psychodynamic side and the ERP side. So you can speak to both sides of that coin, which is so cool. So thank you so much for being with us. And if anyone has any questions for Sara, I will. How can they get in touch with you? What would be the? How would you like that?
They can email me at my name. So Sara Vicendese. That's a tough one. So SARA. Well, you'll have it. VICENDESE at or MFT. So Sara Vicendese, MFT, like marriage family therapy, at gmail.com. I'm happy to answer any questions you might have. I'm happy to, give you my office line, set up a time where we can talk. That's probably the best way. You can also reach my office at 310-909-7253. And I'm happy to get back to you there. And then, my website is just my name.com.
Cool. I'll link that in the notes.
Ways you can reach.
Yeah.
Yeah, and you're very welcome. It's been really been really a pleasure. I'll come back anytime.
Oh, I'm so pleased. Okay, well, thank you, and thank you for listening. I hope you have a wonderful day.